Hello, I'm Dr. Van Besien. I'm the director of stem cell transplant and cellular therapy at NewYork-Presbyterian Hospital. I'm talking today about the use of minimal residual disease in the management of patients with AML specifically. Minimal residual disease is not a new topic. It's been studied for decades. But techniques are evolving, technology is better, we are better able to detect small amounts of disease. We no longer talk about minimal residual disease, but we now mention measurable residual disease, which puts it in context, because the amount of disease one can detect depends on the technology utilized. In AML, there's two major technologies that are used for detecting measurable residual disease, or MRD. One is flow cytometry, and the other is generation sequencing or molecular testing more accurately. That can involve PCR tests, that can involve next-gen sequencing. Here immediately one sees the problem. The technology is rapidly evolving. Generation sequencing is less than a decade old. Flow cytometry becomes more sensitive every year. Another difficulty is the complexity of the assays. Flow cytometry in particular requires great expertise, and not every lab is equipped to recognize small amounts of residual AML routinely. Further, in AML, the detection of flow cytometric detection of disease can depend on the original phenotype of the AML. That said, despite all these limitations, there's clearly an increasing role for MRD detection in assessment of response, in determining treatment, and in predicting outcome. First of all, what are the most reliable MRD tests? They are probably the ones that are used for acute promyelocytic leukemia, the ones used for core binding factor leukemias, those with translocation 821 or inversion 16. And lastly, assays for detection of nucleophosphate, NPM1. NPM1 mutations are present in about 40% of patients with cytogenetically normal AML. Therefore, we can use a molecular assay for detection of NPM1 in at least half of the patients. What should not be used for detection of MRD is the FLT3 assay. At least the routinely utilized FLT3 assay, PCR assay, is not a very sensitive assay and can detect down to 1 to 3% of residual AML cells, which is far from sufficient for detection of leukemia or for detection of minimal residual disease. So let's assume for the rest of the talk, couple words first about usage in APL. We have a very useful NGS test or molecular test for detection of APL. Where is it used? Most patients with acute promyelocytic leukemia in remission, but the ones who do not achieve MRD status will require further consolidation. That consolidation can be in a number of fashions. One is an autologous stem cell transplantation. Second, in NPM1 mutated AMLs, how do we use MRD testing? First of all, during induction. During induction, when we achieve an MRD negative state, one often comes down to the conclusion further consolidation is not necessary. In other words, allogenic transplantation is not necessary. I would not necessarily go that far. That decision depends in part on the MRD assay, but is further determined by additional characteristics of the leukemia, such as chromosomal abnormalities, other molecular abnormalities. For example, FLT3 mutations in the presence of NPM1 still require consolidation with allogenic transplantation. Vice versa, age, absence of a donor, frailty of a patient will be strong arguments against transplantation. What about the patient who remains MRD positive after induction therapy? Should that patient undergo transplant, or should we delay transplant and try to achieve MRD negativity? Another difficult question. depends on what the patient has received before and what the chances are of obtaining a complete remission. Let's assume for a moment the patient has just received 3 and 7 therapy, cytarabine and daunorubicin, remains MRD positive. At our center, at least, we will often give thought to giving another induction, for example, a venetoclax-based, venetoclax and hypomethylating-based induction, and trying to achieve MRD negativity, because it is clear that those patients transplanted in an MRD negative state do considerably better than those who are transplanted with MRD positive disease. That said, the jury is out, because those MRD positive patients then receiving venetoclax, decitabine, or whichever other new or established treatment they are receiving don't always achieve a remission, don't always achieve an MRD negative state, and sometimes more time is lost. Vice versa, even though the results with allogenic transplantation are worse in MRD positive disease, they are not zero. There's a fraction of patients, and a substantial one, anywhere between 20 and 30%, who will still obtain prolonged and even durable remission with the allo transplant. So perhaps they should even, it should drive us even more toward going to a transplant, and then it may guide us also toward choosing a more intensive conditioning regimen, because those are the patients, the MRD positive ones are the patients who really derive benefits from myeloablative conditioning. Vice versa, the MRD negative one, based on data from Dr. Hurrigan et al., do not require myeloablative conditioning and may be spared their toxicity and can receive reduced intensity conditioning. Lastly, an emerging area of interest is the use of MRD testing after transplant. Clearly, when one checks around day 30 or day 100 after transplant, a fraction of patients will remain MRD positive. What to do about those patients? For long, there was no real answer, but increasing data suggests that various forms of maintenance therapy may benefit those patients. For example, those who have FLT3-ITD mutations can benefit from further consolidation with a FLT3 inhibitor. For others, the cytabine may be given, or even in some cases, TKIs directed against CML may be beneficial in certain mutations of leukemia. Vice versa, MRD negative patients may not need such maintenance and may be spared their toxicity. So in sum, MRD is important, is gaining importance every day, but it is extremely complex. And one needs to discuss with an expert, be it a pathology expert or a leukemia doctor, or both preferably, about which assay to use in which situation. The assay we use today is not the assay that we will use tomorrow or next year. And the data we have today on benefit or lack thereof in various conditions will also change rapidly. With that, I thank you for listening.